Good evening, one and all. Hi. Hello. Hi. I welcome you all for this Cornea Pourri session. I can see Padmaja, Dr. Padmaja. And who else has joined? All the speakers are there?
Shubhangi also is joined.
Dr. Shubhangi, yes. Okay. Okay. Once again, there's some disturbance. Okay. Yeah. Welcome all of you and welcome all the delegates for this Cornea Pourri session. And this is a real medley of different diseases of cornea, and as well a medley of we have experienced eminent speakers and we have young dynamic speakers as well. So let's hear from all of us and let's learn how they manage each of the cases which they are going to present to us. May I invite Dr. Padmaja Hanji to talk about conjunctivitis in different age groups. Conjunctivitis being a very commonly seen disorder, and we are eagerly waiting to see how Dr. Padmaja wants to treat each of in different scenarios, different age groups. And one thing I want to say here is that the COVID has had multiple effects. And some positive thing about is conjunctivitis has become kind of rarity. We don't see many epidemics nowadays. Otherwise, many episodes of conjunctivitis would be frequently. I mean, it's been long since I saw a case of conjunctivitis of late during this COVID time. So maybe some plus point of this pandemic. Anyway, Dr. Padmaja, carry on. Is Dr. Padmaja there?
Ma'am, I thought the pre-recorded version will be playing.
Yes. We are waiting for the recording to be played.
Oh, sure. Yes, ma'am. Wait for a second, ma'am. It will be played.
Okay. Yeah.
Conjunctivitis is inflammation or infection of the conjunctiva. It's the most prevalent etiology of redness and discharge. It can affect people of any age, socio-economic, or demographic status. Conjunctivitis can be infected or non-infected. Can be hyperactive. The most common cause of infective conjunctivitis is virus. Adenovirus being the majority. Others are simplex, and enterovirus. Conjunctivitis prevalence is variable depending on the patient's age, sex, and time of year. It's common during up to less than 7 years of age, and a slightly higher prevalence is seen among women. And in children, most commonly seen in the month of March, whereas the overall other population is seen more. The most common cause is viral conjunctivitis in both overall and in the adult population. Bacterial is the second most common cause of conjunctivitis, with children being the majority of people. Allergic is the most frequent cause. Coming to neonatal conjunctivitis or ophthalmia neonatorum, this is a conjunctivitis seen in the newborn during the first month of life. If the onset within the birth is within the other bacteria should be considered. Herpes simplex virus is usually seen if the onset is within 5 to 7 days, and if it's more than 1 week, chlamydia trachomatis is the most common cause. In children, bacterial is the most common cause of conjunctivitis. The highest rates are seen in less than 7 years of age, with a peak incidence between 0 and 4 years. Haemophilus influenza, Streptococcus pneumoniae, and Moraxella catarrhalis are the most frequent causes of conjunctivitis in children. Otitis media can be usually associated with Haemophilus influenza conjunctivitis. Amongst the viral conjunctivitis, adenovirus is the most common, with pharyngoconjunctival fever being common in children. In allergic, VKC or viral keratoconjunctivitis, atopic are commonly seen in children and young adolescents. Retinal keratoconjunctivitis is also common in children. In contrast to children, conjunctivitis in adults is mainly due to viral. Adenovirus being the most common, can be simple follicular conjunctivitis or pharyngeal conjunctival fever or epidemic keratoconjunctivitis. The important aspect is there is significant corneal involvement in viral conjunctivitis. In contrast to children, Staphylococcus species, Streptococcus pneumonia, Haemophilus influenza, Chlamydia, and Gonococcus are the common causes of bacterial conjunctivitis in adults. These are the other causes of allergic conjunctivitis which is usually seen in adults. When a patient comes to us with red eye, we should do a focused history and a thorough ocular examination. This is a suggested algorithm for suspected acute conjunctivitis. In the absence of other symptoms and only discharge, based on the type of discharge, we can determine the cause of conjunctivitis. But in case a patient presents with us with pain, photophobia, and blurred vision, we should always rule out other causes of red eye. These are the classical symptoms and signs of the three most common causes of conjunctivitis. So we can see that all the signs and symptoms are not very specific to any of these causes. If there is suspected viral conjunctivitis associated with skin lesions, we should always do a fluorescein examination of the cornea to rule out herpes simplex keratitis. Like itching, papilla, and follicles are the other non-specific kinds of conjunctivitis. The non-infective causes can be drug, chemical, and toxin-induced conjunctivitis, and also certain systemic diseases. Eyelid cultures and cytology is rarely indicated. They are reserved for usually in recurrent conjunctivitis, which are resistant to treatment, suspected gonococcal or chlamydial infection, suspected infectious neonatal conjunctivitis, and adults presenting with severe purulent discharge. The treatment or management of conjunctivitis should include patient education to decrease the rate of transmission. Bacterial conjunctivitis, which is typically self-limiting, can be treated to reduce the duration of symptoms. The choice of antibiotics are usually broad spectrum, though there is no significant difference in achieving clinical cure amongst those. Fluoroquinolones can be added for empiric coverage for pseudomonas in contact lens wearers. Coming to the specific treatment of conjunctivitis, gonococcal conjunctivitis in both neonates and adults should be treated with ceftriaxone, along with treating chlamydial infection with azithromycin. It can be combined with saline irrigation of the conjunctiva until the discharge is eliminated. Systemic treatment in infants, even in the absence of conjunctivitis, should be given if they are born to mothers with active gonorrhea. Fluoroquinolone or topical erythromycin or gentamicin can be added if there is corneal involvement. Chlamydial conjunctivitis, neonates usually respond to topical erythromycin or sulfacetamide. Systemic erythromycin for 14 days is recommended. In adults, tetracycline 1% ophthalmic ointment twice daily is recommended for 2 months, along with any of the oral antibiotic regimens. Patients and their sexual partners must be treated and a co-infection with gonorrhea must be investigated. The treatment of viral conjunctivitis is primarily supportive and to target symptomatic relief with cold compresses and artificial tears. Antiviral medications are not found to be very useful, and topical antibiotics are not indicated. Since it's highly contagious, hand washing, strict instrument disinfection, and isolation of the infected patients is recommended. Topical steroids are reserved for patients with conjunctival membranes and with subepithelial infiltrates. Herpes simplex conjunctivitis and keratitis can be treated with antivirals like trifluridine, acyclovir 3% or topical dasacyclovir gel. Oral acyclovir 400 mg for 7 to 10 days can be used to limit epithelial toxicity. The treatment of herpes zoster includes a combination of oral antivirals and topical steroids. Moist warm compresses and topical antibiotic ointment can be given for cutaneous lesions. The treatment of allergic conjunctivitis is mainly to avoid allergens. Along with that, we can give artificial tears, cold compresses. Topical antihistamines alone are in combination with vasoconstrictors and topical mast cell inhibitors. Topical steroids are to be judiciously and selectively used. Oral antihistamines be given in moderate and severe cases. In cases of steroid-sensitive or steroid responders, we can use steroid-sparing agents like topical cyclosporine and topical tacrolimus. Systemic therapy can be indicated in chronic ocular surface inflammation, unresponsive to topical treatment, progressive cicatrization, peripheral ulcerative keratopathy. This is usually done in coordination with an internist or a rheumatologist. In non-infectious conjunctivitis, removal of the offending agent often leads to resolution of symptoms. All cases of redness may not be due to conjunctivitis, so we should always keep a differential diagnosis and rule out the emergent causes of vision loss. Conjunctivitis is easily treatable, usually benign and self-limiting. Complications are very rare. Patients with herpes zoster virus are at higher risk with corneal complications followed by uveitis. Even patients with gonococcal conjunctivitis are at higher risk for corneal involvement. A little small mention about the COVID-19, which has become a global pandemic transmitted by SARS-CoV-2. The prevalence of ocular manifestations are at around 11.03%, most frequent being conjunctivitis, uveitis, retinovascular, and neuro-ophthalmic disease. So conjunctivitis can present itself as follicular, viral, hemorrhagic, and pseudomembranous conjunctivitis. In children, it is usually seen as a Kawasaki disease-like condition known as multisystem inflammatory syndrome. These are common in patients with severe systemic symptoms of COVID-19. Though a sole and initial manifestation of conjunctivitis is rare, we should always suspect, especially in these times. The take-home message is conjunctivitis rarely causes permanent visual loss or structural damage. Patient education and importance of hand hygiene is very crucial to prevent transmission. Avoid using indiscriminate use of topical antibiotics or corticosteroids. In cases of chronic or recalcitrant conjunctivitis, we always rule out other causes like underlying malignancy or any other adjunctive disease. All red eye is not conjunctivitis, so we should always stay vigilant to rule out sight-threatening conditions. I would like to thank the audience and also the organizers of Post-Op Glaucoma for giving me this opportunity. Thank you.
Thank you, Dr. Padmaja. That was a very nice presentation. I know in 10 minutes, it's very difficult to cover conjunctivitis. So just I want you to elaborate because for the benefit of whoever has joined as delegates, I want you to elaborate the management of viral conjunctivitis. You have stressed on the point, many points, but then if you can just sum it up quickly so that some points should be like, very clear.
Yeah,
Because,
usually only if there is some corneal involvement, I usually start steroids, ma'am. Otherwise, it's mainly artificial tears. That's how I treat.
Did you mean that a case of EKC, epidemic keratoconjunctivitis, you would start the case with topical steroids?
Low dose steroids, yes, ma'am.
Okay.
And if there is any membranes or pseudomembranes also, then also I give low dose steroids to start with.
Okay.
I would like to know how others would manage this viral conjunctivitis.
Anybody in the other speakers would like to put in their views about the management of EKC, basically?
Because when we use antihistamines and vasoconstrictors, I have seen they have a lot of redness which persists for a longer time. And
yes, true, very true. Antihistamines and vasoconstrictor cause rebound yeah, so better to be avoided.
Yeah, and they also complain that they are not very comfortable with those those antihistamines.
In my practice, I would prefer to use the lubricants, topical artificial tears, and maybe some anti-inflammatory in the product, NSAID. I do not use topical steroids because they are self-limiting the lesions and then disappear on their own. And I always would like to explain to the patient, this is one conjunctivitis patient who needs some chair time. We need to explain to the patient that its course has its course takes about 6 to 8 weeks for the resolution of the lesions. And unless and until they are in the visual axis and bothering their day-to-day activity, I would avoid topical steroids as much maximum possible.
True, ma'am.
So,
True.
yeah, because I've had many patients who've been coming with recurrences, and then it is very difficult to manage these recurrent cases of
Yes,
EKC.
ma'am. And it ends up that patients have already been using steroids by the time they visit.
Yes, yes. So they are very difficult to manage. So I just wanted to make it very clear. I mean, anybody has any difference of opinion, please.
Yes, ma'am. I just wanted to add few points.
Yes.
What I feel is like initial stage of conjunctivitis, if it is mainly redness is there is no chemosis, late edema. Those cases, I think we can manage with an antibiotic with an NSAID combination and lubricants. And when if there is an acute blown conjunctivitis, like it's a severe chemosis is there or late edema is there with a pre-auricular lymphadenopathy is there. In that condition, I think we can add topical steroid. And if there is a corneal involvement is there, like SPK and all, I think we can add a topical antiviral, especially ganciclovir can be added, I feel. So I don't know, like how other.
Dr. Vinay, would you like to add few points over here?
Yeah, please. Yes.
Yeah, actually, yes. First and foremost, no role for antivirals here. It is adenovirus, and there is absolutely no evidence to say that antiviral works here. So whether it's ganciclovir, acyclovir, no.
True.
And acute stage, it is mainly supportive therapy. Does antibiotics have role? No. Does NSAID have role? No. In fact, I feel NSAID should be avoided because it induces a lot of toxicity on the surface. On these, badly inflamed eye, it is better to avoid NSAID altogether. Lubricants, I do give antibiotics basically for the medical legal thing. That's it. Probably 3 or 4 times. That is what I give antibiotics. And then steroids definitely has a role, but in very selected cases. Okay, in acute stage, the indication for steroid for me is severe inflammation resulting in chemosis, severe, pseudomembrane, because all these can have, adverse effects by the time the patient heals without steroids. If the inflammation persists for long, you can have, the pseudomembrane evolving to true membrane with scarring, cicatrization, and post conjunctivitis dry eye is quite well known. So this is the thing. Now for cornea, well, as you said, it is indicated only if it starts affecting the vision or if the patient becomes terribly symptomatic. And then, yes, there is always a risk of, this evolving to a kind of steroid dependent keratitis. So that has to be always kept in mind. And once it becomes steroid dependent, then we have to think of agents which kind of, steroid sparing agents like tacrolimus or cyclosporin or one of those.
Yeah, very well said. True. But only another one point, this is more glitch here. Another one point is that the EKC has the corneal lesions starting in the second week of the disease phase. So initially when the patient present with, we do not know whether we are dealing with which strain of adenoviral conjunctivitis, so whether it's the EKC strain or the regular, the other strain of adenoviral. So there lies the decision-making importance where whether you want to start steroids, because many a times I have seen in my practice, multiple times they come with steroids. And then once they come with steroids and it becomes very difficult. I still have people coming for 2 to 3 years with recurrent episodes. A disease which resolves by 6 to 8 weeks is carried on for many years, 2 to 3 years easily with multiple episodes of recurrence. So that one thing we have to be very careful with. Anyway, thank you, Dr. Padmaja.
Thank you, ma'am.
Let's move on to, I think it's mine only. Ms. Saujanya, could you please play my video?
Yes, ma'am.
Of course, one for giving me this opportunity. I'll be speaking about PK versus DSEC versus DMEC in endothelial diseases. Corneal transplantation has undergone a tremendous change in the past 2 decades. It has become layer-specific transplantation in the sense the disease layer is selectively targeted and replaced. With this background, I would like to put the topic as not as a pure comparison between the three different techniques, but as the three different techniques available with specific indications for each of them. So all the three techniques have their own specific indications for which they should be offered, and the benefit should be passed on to the patient as each one scores over the other in that particular scenario. And as we are all modern day corneal surgeons, we should all be well versed with all the three techniques and use them when they are specifically indicated. The basic technique all of us are aware of. The DMEC procedure consists of transplantation of the descemet membrane and endothelial complex. DISSEC has the additional stroma into it, that complex, and other than DISSEC has endothelium, descemet membrane, and stroma of 60 to 100 micron thickness, and parenteral keratoplasty is the full thickness. When we look into the each of the technique, there are specific indications. Like for example, for DMEC, we have its own specific indications in the form of endothelial failure without a significant stromal scarring or vascularization and with stable anterior chamber situations. So all of those endothelial dystrophies, it can be handled with the DMEC procedure. A PBK case or a regraft case can be handled with provided there is no significant stromal scarring. This technique involves peeling of the descemet membrane of the donor cornea with the scuba technique. With the help of simple instruments like a McPherson forceps can be used to peel the descemet membrane. And once it is peeled, this is an important step, according to me, the stamping of the descemet membrane from the stromal side. And then if the stamping is adequate, orientation becomes easier when during the effort of unscrolling of the descemet membrane in the anterior chamber. Once the stamping is done, the scroll is prepared and injected into the anterior chamber with the help of regular IOL injectors. And then the technique of unfolding the scroll with the tapping, different types of tapping technique can be achieved. And frequent shalling of the anterior chamber aids in the unfolding of the descemet scroll. With the good stamping, the unfolding can be oriented well, and it is attached to the stroma with the help of an air bubble introduced into the anterior chamber. The advantage of this technique is that it is a sutureless procedure and it has a faster wound healing and faster visual rehabilitation, superior visual rehabilitation with a decreased incidence of allograft rejection. All this with no requirement for expensive instruments. But of course, it has its disadvantage in being a technically demanding procedure with a steep learning curve. And also, the incidence of graft detachment is higher as compared to the other EK procedure, but it can be settled with rebubbling. These are the indications of DMEC. What about the situation which has complicated anterior chamber situations? So in such scenario, like at the previous glaucoma surgery with the tubes and shunts in the T chamber and large iridectomies, or in cases of aphakia, in such situations, DISSEC comes handy. The spectrum of indications are same for DISSEC and DMEC, but as far as the the quality of vision is concerned, the DMEC scores over DISSEC. And in situations like the anterior chamber, as mentioned earlier, the complicated anterior chamber situations, DISSEC scores over the DMEC procedure. As it has a thicker graft, it is easier to unfold, and the manipulation in the anterior chamber is very minimal. The procedure of DISSEC involve dissecting the stroma and preparation of the graft. Either manual dissection or automated dissection can be used. And then this prepared graft, after scoring the Descemet's membrane, diseased Descemet's membrane, is introduced into the anterior chamber with the help of forceps or glides, and then air bubble is injected into the chamber to help in the attachment of the graft to the bare stroma. This technique has the advantage of being easy to master and then good repeatability. As far as the Estimatism is concerned, it is much less compared to the conventional technique. And disadvantage is that the endothelial cell loss in both the techniques, the endothelial cell loss is considered to be greater compared to the conventional technique. But when it is a cumulative cell loss is assessed at the end of 5 years or 10 years, it becomes comparable with the penetrating keratoplasty, and the graft dislocations are manageable with the rebubbling technique. So this being the situation for the compromised anatomic anterior chamber situations. But what about situations where you have a failed vascularized graft, or a situation like this where you have the corneal scarring in a compromised endothelial situation, corneal scarring affecting the visual axis with associated vascularization, and also has a dilated pupil. In such situation, our gold standard penetrating full thickness graft comes handy. Or rather, I would like to put it across as penetrating keratoplasty should be offered in those of the cases of endothelial disease which has stromal involvement as well. The technique we are all well aware of. The diseased cornea is replaced in full thickness with the donor cornea, optical grade, and secured with 10-0 nylon sutures, either interrupted or continuous sutures. So the advantage has its good track record, and surgeons' experience are the main plus points here. Of course, it has its own list of complications in the form of lengthy post-op visual rehabilitation, suture-related complications, higher rate of rejection, weak graft-root junction. We have enough evidence in the literature to compare all the three techniques, and then how each one scores over the other. So when we compare generally the three techniques, we can understand that DMEC scores over Dissect in terms of better and faster visual recovery. And when it comes to the graft attachment rate, the Dissect has a lower rate of graft attachment, and then the rebubbling also is easier here. So it can be reserved for those of the difficult anterior segment, anterior chamber situations where unfolding and attachment is not very tricky. And as far as the cell loss is concerned, the cumulative 10-year cell loss is comparable with the conventional penetrating keratoplasty, and the DMEC and Dissect mean endothelial cell loss at the end of 5 years also is comparable. And when it comes to the graft rejection, DMEC scores over the other two techniques in having the lowest rate of rejection, quoted as 1 to 2%, as against about 10 to 12% with Dissect, and around 18% in the penetrating keratoplasty. The advantage in the EK, both the EK techniques are being here that they don't have the majority of the anterior stroma getting transplanted into the patient. So with this, I would like to conclude by saying DMEC should be reserved as the therapy of choice in all the endothelial diseases without significant stromal scarring. And Dissect should be kept as a backup for complicated anterior chamber situations. And PK is best reserved for those of the cases which has, in addition, the stromal involvement and the stromal scarring. Thank you. Yeah. Anybody wants to add any comments? Here, I just wanted to put across.
Yeah.
Yeah.
Question. Yeah.
Yes. Yeah.
So when there is graft detachment in case of DMEC, how many times you have the maximum times you have rebubbled it? Because after rebubbling also sometimes the graft detaches. Have you rebubbled again and again in those cases?
Of course, yes.
Or the one-time rebubbling is good enough and it gets attached.
In my initial cases, I used to have the maximum number of rebubbling instances. I have rebubbled my initial stages, like, maybe 2 times, or one case I must have taken up 3 times also. So over the period, I learned the art of, like, some crucial steps. So stamping, I felt, is very, very important. So it starts, there are various stages. I mean, like each stage we have various points we'll have to highlight here, like taking a donor tissue, peeling also becomes easier if the donor tissue is between 45 to 60 years, all those points are there. So stamping is very important. So once you do the stamping and you know which is the stromal side and which is the endothelial size in the anterior chamber, then I feel the chances of need for rebubbling or the detachment is reduced to a lot minimum. So that makes a lot of difference. Initially, I was not stamping, and then I was like, used to have this problem of detachment and rebubbling. And another point here I would like to make is there could be some peripheral detachment even now in some of the cases. But I have seen many a times if we just observe them and then, like, those areas there will be epithelial edema and patient could be symptomatic. Just put a BCL over it and then observe and then spontaneously resolve. But if you see that the end is curled up towards the stromal side, that is not going to resolve spontaneously. Such instances you have to go in and bubble them. And I use most of them air only. I don't use any of those isoexpansile gases. No,
And one doubt, ma'am, and how do you manage that peripheral part of the this like bullous area? Like, do you do routinely puncturing or you leave it? Because that may give a problem later.
Yes, definitely. There were, like, it's again with my initial cases, I used to initially thought that, like, you keep seeing many videos and this one. So I was thinking it is right to remove the whole of the descendants membrane, even from the periphery. So, and then you have the whole of the cornea devoid of the descendants membrane, and the donor you're putting around 8 mm. So the periphery would have at least till such time it will have the bullae and edema, and could be bothersome. I have had patient who had to be ultimately, I think, had to be converted because she could not tolerate, and there was a mismatch between the graft size and her corneal size. So, and then later I realized that we really don't have to do that. And in case that becomes bothersome, then I just do ASP at the peripheral part, and keeping the bandage soft lens for a long time, I found it to be beneficial. Like, I somehow keep changing it monthly once and then keep it on for 4 months in such situations where the peripheral corneal edema is going to bother the patient. I keep the bandage lens on, and then I find it to be like, it settles down over time. Shall we move on to the next talk? I think we are lagging behind. May I invite Dr. Anand Balasubramanian to talk about Bowen gland disorders. He's the cornea consultant at Shankara Eye Hospital.
Good evening all. At the outset, I'd like to thank the COSCON team for giving me an opportunity to speak today. The topic that I've been given is Bowen gland dysfunction. Now, as we all know, Bowen gland dysfunction has been reported to contribute 60% of all the dry eye patients that come to our clinic. It appears to be more prevalent in the Asian population. Of late, it has become very important for us to treat and diagnose this condition, especially in the setting of a pre-cataract or a refractive surgery. Now, what are Bowen glands? Now, basically, these are large sebaceous glands that are located in the tarsal plate of either lid, which is found both in the upper and the lower lid. The number of glands that are seen are more in the upper lid than the lower lid, and it is longer in the upper lid as compared to the lower lid. Now, it is the main source of lipid in the tear film, and it constitutes what's called as the mebum. Now, it consists of a complex mixture of various polar and non-polar liquids, cholesterol, wax, esters, free fatty acids, and phospholipids. The melting point is around 32 to 37 degrees Celsius. Now, the main functions of mebum is it provides a smooth optical surface for the cornea at the air-lipid interface. It reduces the evaporation, enhances the stability, and enhances the spreading of the tear film. Now, if it is left untreated, it can increase in evaporative rate, thereby making the tears hyperosmolar and indirectly resulting in instability of the tear film. It can also cause increased bacterial colonization on the lid margin, thereby making the lid susceptible to infections like pellasions and styes. It can also cause evaporative dry eye, and in very severe conditions, it can cause ocular surface inflammation in the conjunctiva and cornea, causing irreversible damage and visual loss. Now, the International Workshop on the Mutant Gland Dysfunction classified or defined mutant gland dysfunction as a chronic diffuse abnormality of the mutant glands characterized by terminal duct obstruction, wherein it causes quantitative and qualitative changes in the glandular secretions, altering the tear film, causing symptoms of eye irritation, inflammation, and in very severe cases, ocular surface disease. Now, the major contributing factors are age, race, then gender, then people who are exposed to a lot of computers, the environment, chronic contact lens wear, and even hormonal disturbances. The major systemic causes include acne rosacea, acne vulgaris, eczema, psoriasis, and Sjogren's syndrome. Ophthalmic diseases mainly include chronic contact lens wear, hemorrhagics, and dry eye disease. Patients who are also dyslipidemic are prone for this particular problem, and even chronic medications can cause mutant gland dysfunction. Now, the international classification, they classified it based on the amount of secretions as the low delivery and the high delivery. The low delivery can be hyposecretory or obstructive. The hyposecretory is also called as the mutant gland sicca. The obstructive can be cicatricial or non-cicatricial, and the major cicatricial causes include trachoma, ocular pemphigoid, Stevens-Johnson syndrome, and even chronic atopy. The non-cicatricial causes include mainly seborrheic dermatitis, acne rosacea, and psoriasis. In the hypersecretory state, also called as the mutant sicca, seborrhea, it is more common in patients with acne rosacea. Ultimately, both of these will eventually lead to alteration of the tear film and cause clinically apparent inflammation and ocular surface disease. Now, coming to the major etiology, the main pathology lies in the obstruction of the mutant gland orifice, which is either because of hyperkeratinization of the ductal system or increased viscosity of the mebum. Now, once the obstruction occurs, there is stasis of the mebum, and that leads to dilatation of the ductal system, and there is atrophy and glandular dropout and reduced secretion. And even obstruction indirectly can also cause a low delivery to the lid margin. Both the arms eventually lead to evaporative dry eye with tear film instability, increased evaporation of the tears, hyperosmolarity, and finally ocular surface damage. Now, coming to the diagnosis, it can be diagnosed mainly based on the symptomatology, where the features or the clinical features are more pronounced in the morning on waking up. The various clinical signs can be seen on the eyelids, the meibomian glands, the tear film, and the ocular surface, and also the investigations that shall follow. The main assessment that we do mainly is the symptom assessment in the form of questionnaire, and we can also check the blink rate and the partial blinks. We can evaluate the lower tear film meniscus height, the TBUT and the non-invasive BUT if it's available. Then the corneal and the conjunctival staining patterns can be seen either with the Leishman or the Rose Bengal, and then the Schirmer's test, and if it is available, even the tear osmolarity. In addition, we can also quantify and quantify the lid features that we see in the lid, and also the expressibility of the mebum, both in consistency and the number of openings that are seen, and also the memeography, where we can quantify the amount of dropouts. Now, the various eyelid features that are seen in the mutant gland dysfunction is eyelid thickening, then overall lid margin injection or hyperemia. We can see dimpling or the notching, then the mutant gland capping. There can be pouting of the mutant glands. In very severe, it can cause madarosis, and also it can cause lid marginal keratinization as well as telangiectatic vessels along the lid margins. These are just the various clinical photos showing you the various eyelid abnormalities that are seen in MGD patients. Now coming to the mebum, it can be assessed both in terms of consistency and the number of mebum gland openings that are seen by pressing the lower lid either with 2 fingers or with 2 buds, and the consistency can be seen as to whether it is clear in grade 0, or if it is toothpaste like consistency, we can classify it as grade 3, and also the number of glands that are seen expressing out the mebum. In grade 0, all the glands will be expressed, whereas in grade 3, none of the glands will be expressed. Now, looking at all these clinical, or looking at all the clinical pictures in terms of mebum gland expressibility and the amount of glands that are seen versus the symptoms and the corneal staining patterns, we can stage it as 1, 2, 3, and 4, and the plus disease, where there can be associated disorders of the ocular system as well as the eyelid. Now, in addition to whatever we have seen, the newer modalities that are currently being used is a LipiView, which is marketed by the Johnson & Johnson company, which is based on the principle of interferometry. It does a real-time visualization of all the lipid layers, visualization of the lipid layer to evaluate the dynamic response of the lipid to the blinking. It also has a very special technology where it measures the lipid thickness in the submicron level, and it also gives a video and analysis of the blink dynamics. In addition to that, it also gives a high definition imaging of the mebum gland with a dynamic mebum imaging system. Now, these are just the clinical photographs of the mebography that is picked up by the LipiView. The one on the left are the normal glands, both in the upper and the lower. And the one on the right is the dropouts in the upper and the lower lids. Now, based on the number of dropouts, it can be quantified or graded as grade 0 to grade 4, where grade 4 shows more than 75% gland dropouts. Another instrument that is also used is the ocular surface analyzer, which is more compact and portable as compared to the LipiView. It does an assessment of all the 3 lipid layers. In addition to that, it also maps the mebum gland. It does the analysis of the tear film breakup time, both the invasive as well as the non-invasive. We can also grade the lipid layer thickness and the stability, and it also gives a quantification of the meniscus. Now, based on the symptoms, the lid margins and the expression of the glands and the consistency of the secretion and the ocular surface staining, it can be classified as asymptomatic, mild, moderate, and severe. Now, coming to the treatment of the mebum gland dysfunction, like I said, based on the grading, we can give the treatment. In asymptomatic patients where they have only very minimal signs, patient education along with warm compresses both for the upper lid and the lower lid can be given. In mild variety, in addition to the lid scrubs, we can also give any omega-3 nutrition supplements or topical antibiotics. In moderate variety, in addition to the ones that we give mild, we can also give a topical antibiotic steroid for 2 weeks in tapering, as well as the oral tetracycline derivatives. In very severe forms, in addition to whatever treatment that has been given in the moderate, in addition to that, we can also give other inflammatory therapies for the dry eye. Now, the problem is we still have not treated the root cause for the mebum gland dysfunction, because even in warm compresses, what happens is one of the main problems with mebum gland dysfunction is the melting point increases. So even the warm compresses or any of the other treatments that I've described does not address that. And that is why newer treatment modalities like the LipiView comes into play, which basically consists of an eye cup and a lid warmer. And a lid warmer is just like a sterile contact lens which fits on the sclera and doesn't come in contact with the cornea. So this gives a precise amount of temperature directly to the lids, and it also has an eye cup which has an inflatable bladder. And so what happens is, along with the heat, it liquefies the mebum, and there is a pulsatile compression on the lid wherein the mebum secretions are secreted out. Now, all the studies have shown very dramatic improvement in the dry eye parameters, such as the tear breakup time, the lipid layer thickness, and reduction in the OSDI as well as the speed scores, indicating symptomatic improvement. Now it depends from patient to patient, but in general, the duration of effect is anywhere between 6 months to 2 years, and the treatment time is only around 12 minutes. The limitation, of course, is always the cost factor, and if there is gland dropout of more than 50%, this treatment is questionable. The other one that is also used these days is intense pulse light, also known as the IPL, which was initially used in rosacea patients and other skin condition. In this there is a polychromatic light source with a wavelength of around 500 to 1200 nanometers, and it has a probe where around 10 to 15 spots are put on either side of the face, and it can be repeated up to 2 passes on each side. It works on the principle of selectively thrombolizing the vessels along the meibomian gland, indirectly reducing the inflammation. In addition to this, the heat generated also helps in liquefying the contents of the gland. Thank you.
Thank you, Dr. Anand. That was a very nice presentation. We are running short of time, but then if Dr. Anand, could you just, I know you nicely explained about the different stages and the different modalities of treatment. If you can just summarize as to like when we do start treating a case of MGD, when you see 1 or 2 capping of the lid margin, or like, when would you clinically, just to sum it up. Is Dr. Anand here? Okay. Maybe he's not there. Okay, now I invite the next speaker, Dr. Shubhangi Patil, young and dynamic. She'll be giving a talk on stromal corneal dystrophies. Over to you, Dr. Shubhangi.
Good evening, everyone. Today I'm going to discuss stromal corneal dystrophies. At the preset of my presentation, I want to thank COSCON team, scientific committee members, and Dr. Ellen Kumar sir for giving me this opportunity to be on this dais. Corneal dystrophies, it is a group of heterogeneous disorders which are inherited, bilateral, symmetrical, slowly progressive, and they are not associated with systemic diseases or any environmental factor. Genetic mutation often leads to abnormal proteins which result in accumulation of the insoluble material within the corneal stroma. There are certain exceptions. Some dystrophies are present as isolated cases. They may be unilateral or asymmetrical, and some are associated with systemic diseases like lattice corneal dystrophy type 2, which is associated with systemic amyloidosis. Before jumping to the dystrophies, we should know the differentiation between dystrophies and degenerations. Unlike dystrophy, degeneration are non-inherited disorders which are unilateral, asymmetrical, they are progressive, and generally they are located peripherally. And they involve more than one corneal layer, and there is always systemic diseases associated with degenerations like collagen vascular diseases or hypercalcemia or hyperlipidemia. And degenerations are always present with vascularization and inflammation. So this is clinically important to differentiate between dystrophy and degeneration. International Committee for Classification of Corneal Dystrophies, that is IC3D, has revised the classification in 2014, as most of the dystrophies do not confine to the single layer. They were excluded acellular Bowman's layer and Descemet's layer from the classification. And they have categorized the dystrophies into 4 different classes depending on the gene and chromosomal locations. In category 1, we know the genetic locus and gene, and it has well-defined clinical features. In category 2, genetic locus is known, but gene is not identified, though it has well-defined clinical features. In category 3, it has well-defined clinical features, but not a genetic locus or gene is identified. And category 4 is reserved for the newer additions or some ill-defined dystrophies or some suspicious cases where genetic locus is not known and gene is also not known. Transforming growth factor beta 1 associated dystrophies like granular, lattice, avellino, and Rees-Buckler, they are associated, they codes for the keratoepithelium, and chromosome is 5 to 31. This is the IC3D stromal dystrophy calcification. We are going to discuss one by one. The first is lattice corneal dystrophy type 1, which is also known as Bieber half dimer dystrophy. It is transforming growth factor beta 1 associated autosomal dominant disease. Here the deposition of amyloid is present throughout the stroma. This dystrophy starts during the first decade. You can see the fine refractile branching lines or subepithelial dots by the end of first decade. The lines are generally centrally, they start centrally and then move towards periphery. The limbus is paired and they start superficially and they go deep, but Descemet's membrane and endothelium is clear in the lattice dystrophy. By the end of fourth decade, there will be diffuse stromal edema and ground glass appearance. And the lattice lines are more prominent on the retroillumination. It is always associated with frequent corneal erosions. Patient complaints of discomfort, pain, and there will be diminution of visual acuity. But dramatic visual impairment occurs within fourth decade. It is a progressive dystrophy, often leading to need of keratoplasty in fourth decade. On histopathology, you can see the amyloid deposits in the stromal lamellae, which is highlighted with the Congo red stain. Then on polarized light microscopy, you can see the birefringent filaments, and lattice lines are associated with the hyperrefractive filaments on the in vivo confocal microscopy. Then lattice corneal dystrophy type 2 is gasoline type dystrophy. It is always associated with the familial amyloidosis, also known as Meritoja syndrome. It is not a true dystrophy because of its systemic association. Patient presents with mask-like face, dermatochalasis, lag of thalamus, cranial and peripheral nerve pulses, and because of amyloid deposition, their skin will be very dry and lax. There are different lattice variants like lattice type 2 and type 3. In type 2, the lattice lines are more peripheral and less numerous compared to type 1. And central cornea is involved very late, so vision drops by the end of 6th decade. In lattice type 3, the thick translucent lines are there, mainly in the center. Differentiation between 3 different types of lattices. In lattice type 1, symptom starts appearing by the end of first decade. Visual acuity drops dramatically by 40 years of age. Corneal erosions are more frequent and more delicate lines will be there, and they are numerous in that. And in type 2, you have very few short fine lines which are more radial and more peripheral. In type 3, there are thick lines. Now we are moving to granular corneal dystrophy type 1. It is again transforming growth factor beta 1 associated dystrophy, which is autosomal dominant. It may start as early as by the age of 2 years. In children, there may be many times it may be associated with vortex keratopathy, though white granular material deposits in the superficial stroma. And it gives the breadcrumb appearance, and the lesions are mainly in the center. They spare the periphery, and the clear cornea is present between the lesions. That is the classical of granular corneal dystrophy. Patient may present with glare photophobia. Diminution of vision occurs in the later stages. And in granular corneal dystrophy, hyaline deposits are seen which are stained with nascent trichome stain. Granular corneal dystrophy type 2, also known as Avellino dystrophy. It is again transforming growth factor beta 1 associated autosomal dominant dystrophy. It has features of both, like it has a granular deposits as well as filaments, rod-like filaments deposit like lattice. So it is also known as combined granular lattice dystrophy. Vision generally decreases late in the disease as central axis gets involved. Mild corneal erosions are always present there. Now we are moving to macular corneal dystrophy, also known as fair spotted dystrophy. It is autosomal recessive disease associated with carbohydrate sulfide transferase 6 gene. It is the deposition of glycosaminoglycans seen in cases of macular dystrophy. Unlike granular dystrophy, macular dystrophy causes diffuse stromal haze which extends to the limbus, and superficial elevated whitish opacities like macules are seen. There are no clear areas between the lesions, and the main distinguishing feature on slit lamp is cornea is thinner than normal in early stages. but it spreads to the Descemet's membrane and endothelium, causing cornea guttata and corneal decompensation. The glycosaminoglycans accumulation in the stromal lamellae, which is highlighted with Elsham blue stain. To remember these dystrophies and their accumulated material, there is a mnemonic. Marilyn Monroe always gets her man in Los Angeles City. Macular dystrophy, accumulation of mucopolysaccharide, highlighted with Elsham blue. In granular dystrophy, hyaline material seen with Masson trichome stain. And in lattice, amyloid deposition highlighted with the Congo red. In macular dystrophy, it is autosomal dominant and symptom starts within the first decade and dramatic reduction of visual acuity occurs in the first or second decade. In lattice dystrophy, recurrent erosions are more common. In granular dystrophy, unlike macular dystrophy, there are intervening stroma is clear and limbus is paired. In macular dystrophy, thinning of the cornea is the diagnostic feature. And recurrence of pathology in the graft is more common in granular, followed by lattice, and then macular dystrophy. To complete the list, there is a Schindler corneal dystrophy, which is associated with hyperlipoproteinemia. The central comma-shaped subepithelial crystals are seen here. And congenital stromal corneal dystrophy, which is associated with decorin gene. Patient presents by birth with diffuse bilateral corneal clouding, and there is a moderate to severe visual loss. Then flex corneal dystrophy, it is an autosomal dominant dystrophy in which the dandruff-like material is accumulated throughout the corneal stroma, but visual acuity is generally unaffected. For the management of corneal dystrophy, in initial stages, refraction, scleral contact lenses will take care, but for recurrent corneal erosions, bandage contact lens, lubrication and debridement is required. For recalcitrant corneal erosions, anterior stromal puncture and PTK will help in promoting the adhesions between the epithelium and Bowman's layer. Surgery is needed only when the conservative measures fail and patient has severe glare, photophobia or decreased visual acuity. Surgical intervention depends on the level of involvement. If the superficial dystrophy, PTK and SALC will suffice, but even deep stroma is involved, DALC is required, and full thickness involvement, conventional PK is the solution. Before doing any surgical intervention for the dystrophic patient, we have to counsel them basically about the recurrence of pathology in the after the procedure or after the graft. And in case of PTK, residual stroma should be at least 300 micron. SALC is suitable for the granular dystrophy and other superficial epithelial basement membrane dystrophy. In case of deep anterior lamellar keratoplasty, if you don't have the in-house eye bank facility, better to keep a spare tissue because sometimes during intraoperatively microperforation in Descemet membrane occur, and for that time you have to convert it into the penetrating keratoplasty. When there is a full thickness involvement of the opacity or full thickness involvement of the dystrophy or intraoperative complication during the DAL, then conventional penetrating keratoplasty come to rescue. Thank you.
Thank you, Dr. Shubhangi. That was a nice presentation. So generally, so when would you, when a patient walks into your clinic, when would you advise surgical intervention? You have to unmute. You have to unmute. You're not audible. We cannot hear you. Ms. Saujanya, is there anything that we can help her with? Help Dr. Shubhangi? Meanwhile, I would like to ask the question to the other speakers. How would they treat a case of macular dystrophy? Which form of surgical, whatever, transplantation technique would they be preferring? Yeah, Dr. Vinay, what is your preference for a case of macular dystrophy? Visually significant.
It's always a DLK first choice.
Okay.
Okay. And again, you know, lots of factors depends on how the endothelium is. If I can assess them pre-op, it depends on that. But what happens is most of these cases, the haze is so much that it's very difficult to see how the endothelium is. So my first preference is always DLK.
Okay. Okay.
Yeah.
True. I mean, yeah.
How
That's
about
what it's very difficult to very difficult to understand the endothelial status, and macular dystrophy is one thing which it's like, it is different from the all other types of dystrophy, being spreads to from limbus to limbus, and all the layers also ultimately get involved. So I have seen, at least in my experience, whenever lamellar surgeries I've done, that haze. So it so happened that I had to, initially I did a DALK in one eye, and then I was not happy with the haze, neither the patient was. And then I happened to do a penetrating full thickness graft. Even now the patient says I can see better with my penetrating grafted eye and then than the DALK eye. So that haze is always there. Somehow I prefer to do a full thickness graft here, though it is less advantageous as compared to being a intraocular procedure with the extraocular and all that. But I still prefer a full thickness graft in case of macular dystrophies. Any more? Are you back, Dr. Shubhangi? There seemed to be some issue. Okay. Maybe shall we move on to the next speaker? May I invite Dr. Vishwanath to talk on medical management of Bulas keratopathy? Or Bulas keratopathy treatment options.
Very good evening all. First, I thank all the organizers of COSCON 2021 for giving me this opportunity. My talk is on various treatment options for Bulas keratopathy. As we know, Bulas keratopathy is a clinical condition characterized by formation of microcysts and bullae in the corneal epithelium due to persistent corneal edema secondary to the endothelial dysfunction. That means this condition results from failure of the endothelium to maintain the normal dehydrated state of the cornea. Hence, these patients, they have recurrent bullae formations and they suffer from recurrent ocular discomfort, irritation, and when the bullae rupture, they'll have an intense pain, photophobia, watering, and defective vision. These cases, they form most common indication for optical keratoplasty in our day-to-day practice. Bulas keratopathy has various etiologies. In our country, the most common causes are complications arising from cataract surgery, that is due to mechanical damage to the endothelium via instruments, via nuclear fragment, they are rubbing to the endothelium or using a high phaco power and also prolonged phaco time, and vitreous touch to the endothelium following PCR or retained cortex in the anterior chamber rubbing the endothelium, and subluxated eyeballs, they are rubbing the endothelium, and also Descemet's membrane detachment. And also Fuchs dystrophy also forms a very important cause for Bulas keratopathy. Other causes include corneal graft failure, viral endothelitis, and raised intraocular pressure. So these are the few of the pictures of depicting the various causes of Bulas keratopathy. Management of Bulas keratopathy is mainly surgical. Medical management has got very minimal role. Surgical management includes a definitive definitive visual rehabilitative procedures like penetrating keratoplasty, Descemet stripping endothelial keratoplasty, Descemet's membrane endothelial keratoplasty with or without IOL implantation. And palliative surgical treatments, they are mainly aimed at relieving the symptomatic relief to the patients. They include Gunderson's flap, anterior stromal puncturing, amniotic membrane transplantation, Bowman's cautery, phototherapeutic keratectomy, corneal collagen cross-linking. As the previous speaker has already spoken on the optical keratoplasty in detail, so my talk is limited to the palliative surgical options for this Bulas keratopathy cases. In medical management, there are few agents can be used to reduce the symptoms of Bulas keratopathy, like topical hyperosmotic agent, that is sodium chloride in drops and ointment form. These agents help by forming hypertonic tear film by imbibing the water out of the cornea. Hence, they relieve the symptoms to some extent. And IOP lowering agents can be used to reduce the intraocular pressure, hence they decrease the corneal edema and few of the symptoms of Bulas keratopathy. Commonly, beta blockers and alpha agonists are preferred. Steroids can be used cautiously to reduce the inflammation whenever necessary. And lubricants can be used liberally in drops as well as gel form. Bandage contact lenses forms a very important part of the management. They mechanically cover the pathological surface. Hence, they decrease the pain which is associated with the mechanical trauma induced by the frequent blinking. And also, they improve the visual acuity to some extent as they mask the surface irregularity. And these bandage contact lenses should be changed preferably every 15 days. Next, palliative surgical treatments should be considered for the patients who has a very poor visual potential and also who are not very keen on keratoplasty. Here, the primary goal of treatment is just to relieve the symptoms and restore the normal ocular surface. The variety of surgical procedures includes Gunderson's flap, anterior stromal puncturing, amniotic membrane transplantation, Bowman's cautery, phototherapeutic keratectomy, and corneal collagen cross-linking. To explain one by one, Gunderson's conjunctival flap is still commonly used palliative procedure for Bulas keratopathy. Here, a thin flap of conjunctiva is dissected and it is used to cover the cornea. Here, the Tennant's capsule is excluded. The exclusion of Tennant's capsule increases the flap longevity and it prevents the flap retraction. The main advantages here, it reduces the collagenolysis, hence destruction of Bowman's membrane is prevented, hence the recurrent bulle formation will be reduced. And also it reduces the blink related trauma and it provides nutrition to the ocular surfaces through the vascularized flap. The main limitation here is unacceptable cosmetic appearance. These are the pictures depicting the procedure of taking Gunderson's flap. Initially, we have to measure the area to be covered and the similar marking is made on the superior bulbar conjunctiva. Horizontal incision is given on the pharyngeal end of the marking and a thin flap of conjunctiva is dissected carefully and it is cut along the limbus and this peritomy is continued nasally as well as temporally. And this flap with an intact nasal and temporal bridge is covered on the surface and it is sutured with the absorbable suture. And this flap takes at least 3 to 4 weeks to adhere to the surface. Here is the case with the pre-op bullous keratopathy. It is covered with the Gunderson flap. It relieves the most of the symptoms and this is the picture after 1 year. Next procedure is the amniotic membrane grafting. It is the most commonly preferred technique for as a palliative treatment for bullous keratopathy. It is amniotic membrane is an inert non-immunogenic basement membrane. It helps in migration and adhesion of the epithelium. So it not only it is a basement membrane, it also contains various collagen types as well as growth factors. It facilitates in epithelialization and hence it reduces the inflammation and scarring. The main advantages over the conjunctival flap is this amniotic membrane is easier to perform and it gives a better cosmetic appearance. And after grafting, the eye is still eligible for optical keratoplasty if at all planned in later period of time. This amniotic membrane is available as cryopreserved as well as in freshly prepared form, that is a dry as well as a wet form. So it can be used to cover the localized surface or the total cornea can be covered either with an anchoring sutures or fibrin glue. Usually it takes 2 to 3 weeks to adhere to the surface and suture removal can be planned after 2 to 3 months. Next procedure is the anterior stromal puncturing. Here a double bent cystotome needle is used to make a puncture, partial thickness puncture to the stroma. Here the main principle is to induce the localized fibrosis. Hence, it forms a stable adhesion between the epithelial cells and the stroma. And this by fibrotic scarring hinders the aqueous humor from leaking into the subepithelium. Hence, it prevents the formation of bullae and as well as rupture of the bullae. And also, this fibrotic scarring, it limits the exposure of the corneal nerves. Hence, the pain and inflammation will be reduced. And this is the picture depicting the procedure of anterior stromal puncture. It can be done either OPD procedure as well as in the OR. The multiple puncturing is done over the pathological area, either localized or the whole of the pathological surface. And later it is followed by, it can be covered with a bandage contact lens or amniotic membrane. Next modality is the Bowen's membrane cautery. Here, similarly using a unipillar thermal cautery or with an RF cautery tip, fibrotic scarring is created with the cautery. It forms a tight barrier between the epithelium and stroma. Hence, it prevents the formation of bullae and relieves the most of the symptoms of Bulas Ketopathy. And basement membrane polishing can also be done with a diamond burr, which helps in epithelial adhesions and prevents the bullae formation. And phototherapeutic keratectomy, it's a procedure done in many centers. Here the rationale is ablation of it ablates the sensory nerve plexus of the stroma, and hence it reduces the pain, as well as it debulks the stroma and reduces the corneal edema. It can be done superficial ablation or deeper ablation, but the deeper ablation has got better effect in reducing the pain and relieving the symptoms of Bulas Ketopathy. Lastly, corneal collagen cross-linking. It's also a newer modality tried for Bulas Ketopathy, as it causes the cross-linking of the stroma and it strengthens the bond, and hence it relieves the edema as well as relieves the most of the symptoms of Bulas Ketopathy. So with this, I conclude my talk. Thank you for patience hearing. Just to add a few points, actually Bulas Keratopathy, it should be treated like as a palliative therapy, surgical therapy with a multi-pronged approach. What I feel is like it's a after initial debridement, we can do a stromal puncturing along with an Bowen's cautery, and later the area it should be covered with an amniotic membrane and followed by either BCL or it's an optional. So, but the role of PTK and CXL, I don't have much personal experience. So I throw the question for discussion to all the panelists, so they can share their view on PTK and CXL in Bulas Ketopathy.
Very nice elaborate presentation, Dr. Vishwanath. Yeah, even I have not done cross-linking for a case of Bulas Keratopathy. If any other speakers have any experience, maybe we can have their valuable inputs over here. And one point I just wanted to add over here is that while doing ASP, to know how closely we are spacing the puncture marks, we can stain it with fluorescein, and under cobalt blue, you can do the procedure when you're doing it in the OPD, so that with each puncture marks get stained, so it will be easier for you to complete the whole area clearly. Otherwise, you need to call the patients and ask them to have the procedure in a 2 or 3 sitting. The number of sittings can be reduced. Is the next speaker available? Dr. Archana?
Archana is not available, ma'am. After Archana, Vinay is available.
Okay.
Can I play the video? Share the video, ma'am?
Yeah. We have, may I invite Dr. Vinay to deliver his keynote address on keratoprosthesis?
Yes, ma'am. Wait a minute, ma'am.
Yeah.
We all know that keratoprosthesis is an option when nothing else can be done to restore the ocular surface in many cases. In cases like this, a proper graft can restore the vision, while in cases like this, any biological tissue transplanted is likely to fail. History about the keratoprosis dates back to 1789, and then it took a backseat. Later in 1950, with the improvement in science, material sciences and other things, it took a drastic change, and over the last few decades, it has really evolved. Who all can be considered for keratoprosthesis? People who have had repeated unsuccessful corneal transplant, limbal stem cell deficiency, probably recurrent herpetic keratitis, congenital corneal opacities, end-stage disease from Stevens-Johnson syndrome, OCP, end-stage ocular trauma like chemical injuries can all be considered for K-pro surgeries. People with irreversible posterior segment damage like severe glaucoma, retinal pathology, optic nerve pathology, or dense amblyopia are not real good candidates for a K-pro surgery. There are various different types of keratoprosthesis. Basically, K-pro consists of a central optic element or optic cylinder, which is for the focusing of the light onto the retina, and then a peripheral haptic or a skirt. The skirt can be non-biological or biologic. A biologic involves of tooth root, tibia, cartilage. Non-biological can be of PMMA, hydroxyapatite, dacron, and so on and so forth. But of all the keratoprostheses, the two K-pros that have stood the test of time are the Boston keratoprosthesis type 1 and modified osteoodontokeratoprosthesis. Boston K-pro was developed by Mass and Eye Ear Infirmary in 1992. It got FDA approval, and over the years, various modifications has been done, and it has evolved to be of better design with a better outcome. It basically consists of a front plate with an optic cylinder which passes through a central hole in a carrier graft, which is fixed on the back of the carrier graft with a back plate and a titanium locking ring. Consists of an aphakic and a pseudophakic type. This is a short surgical video. Cornea is trephined with an 8.5 or 9 millimeter graft. Then the donor punched with the first, and then a central hole of 3 millimeter made, through which the optic cylinder and the anterior plate is passed. Then the posterior surface, you see the back plate being fixed now, and then a titanium locking ring is used to fix the entire composite. After this, the cornea is trephined, and ECC is done, and PCIOL may be placed if required, or if it is a phakic type, you can just leave it, and then the graft is sutured. So it's a simple procedure which can be performed by any corneal transplant surgeon. At the same time, modified MOKP is done in 3 stages over a period of 6 to 9 months. In stage 1A, the first step is in dissecting off the pannus. If the cornea is not healthy, we will have to plan for a large graft. After removing the cornea, the iris is removed in toto. It is peeled off from the root. Once the whole iris is removed, once the whole iris is removed, the lens is removed, and cryo extraction is preferred here. After the lens is removed, anterior vitrectomy is done, and the corneal graft is sutured. After that, the conjunctiva is used to cover the entire ocular surface. Next, stage 1B plus C is done about 2 to 3 months after the stage 1A. In 1B, cheek mucosa is harvested. It is then trimmed off the fat and the muscle fibers. The mucosa, once the mucosa is harvested, the next step is to go on to the eye and separate the previously closed conjunctiva. All the entire ocular surface from the muscle insertions are exposed. The mucosa is then placed onto the ocular surface and sutured onto the ocular surface to cover the entire eye. This is stage 1B. Once this is done, we proceed to the stage 1C, which is the stage of osteodental alveolar lamina preparation. The canine tooth with the bone is first harvested. This is the mucosa is separated, then the using an electric saw, the tooth with the bone is removed like this. And once the tooth is removed, the mucosa is cleaned from the tooth, taking care not to damage the periosteum around the bone. Then it is thinned to create the lamina, which is 3 to 4 millimeter thickness. Once the lamina is created, a hole is made in the center. Then the enamel is cut off, and after that, the optic cylinder is fixed into the hole. This whole composite is then implanted into the subcutaneous pouch in the maxillary area and left there for 3 to 4 months. After 3 to 4 months, the stage 2 is prepared from the subcutaneous pouch. The lamina is removed. Once after the lamina is removed, the eye is dissected in such a way that the mucosa is separated from the eye. Then the center of the cornea is refined, and the osteodental lamina is fixed there. Once it is fixed, the whole thing is covered back with the mucosa, and the central part of the mucosa is open to to expose the optic cylinder, and this finishes the stage 2. So visual acuity in both these cases is good. In Boston K-Pro, 60 to 70% has better than 6/60, while in MOKP, 70 to 80% has better than 6/60. Retention rates of Boston K-Pro is more than 80%, while of MOKP is supposed to be more than 90%. So both these cases gives good results, and one is a simple procedure and one is a very complicated. So should we need 2 types? Yes, because the indications are different. In Boston, it is done in wet eyes with near normal functioning lids, while in MOKP, it can be done in very severe dry keratinized eye, and the status of adnexa is not that important at all. Pre-op workup in these cases include a proper ocular examination, including a B scan, A scan, and an intraocular measurement in all these cases is basically digital intraocular tonometry or with the fingers. In OKP, additional dental, radiological, and systemic evaluation is essential. A proper psychosocial profile of these patients needs to be done because they should have proper support systems. They should have a realistic expectations and should be willing for a lifelong follow-up. Post-operative, again, involves a proper ocular examination. ASOCT should be done wherever indicated, especially in Boston K-Pro. Fields and disc photo should be done routinely to assess whether glaucomatous damage. Intraocular pressure measurement is very important, and it can be done only digitally in these cases. Post-operatively, Boston K-Pro patients are on lifelong bandage contact lens, topical antibiotics, and topical steroids. MOKP patient, on the other hand, are on surface lubricants and ointment, and for quite some time, they may need tablet diamonds. These procedures are fraught with complications, and it is not a bed of roses either for the patient or the surgeon. For Boston K-Pro, common complications are retroprosthetic membrane formation, sterile corneal melt, secondary glaucoma, infections, detachment of the retina, and multiple recurrent sterile vitreitis. While in MOKP, tooth-related issues like damage to the adjacent teeth while harvesting the canine, oroantral fistula, fracture of the mandible, and late laminar resorption are there. And mucous membrane related problems like trophic changes and atrophy of the mucosa, mucous membrane overgrowth to cover the lamina, erosion of the mucosa to expose the lamina are all known and is quite common. There are certain questions, important questions to be addressed in any patient who is for keratoprosthesis. One of them is whether should this to be, or that is the keratoprosthesis surgery to be performed in a unilateral blind with normal other eye, or in bilateral blindness. The answer is attempt only in cases with bilateral blindness. So in bilaterally blind, should we do a unilateral K-Pro or bilateral K-Pro? The answer is again unilateral K-Pro, because the second eye acts as a standby eye And in case the problems develop in these in the eye with capro later in life. Should primary capro be attempted in dry keratinized eye? Yes, it is a primary capro. In wet eyes, with the advent of stem cell transplants and all, depending on the case, we will have to take a decision whether it's a primary capro or not. Pediatric capro is a little a controversial issue here. From my point of view, I would say no, but then there is a group who strongly believes that we should go ahead with it. Limitations in Indian scenario are the climatic condition which favors multiple and recurrent devastating infections, then socioeconomic profile of these patients, and most of them are in the lower socioeconomic profile, which affects hygiene and causes an immense financial burden on them. Finally, with the proper case selection in these cases with end-stage ocular surface disorders, we can achieve high anatomic and visual success rates, but always anticipate complication throughout the duration of the post-surgery, and these patients should be committed for lifelong follow-up. Thank you, everyone, and I'm extremely grateful for my mentors, Dr. G. Sitalakshmi and Professor Giancarlo Falcinelli, who actually was instrumental in starting MOKP here. Once again, I would like to thank Dr. Ilan Kumaran and KSOS for asking me to give this talk.
Thank you, Dr. Vinay. That was a very nice presentation. There is a lot to discuss actually. We're running out of time. One quick question. What is your most commonly encountered post-op challenge?
It actually depends upon the type of capro performed.
Boston capro.
Boston, the most common is retroprosthetic membrane.
Mm-hmm.
OKP in Indian scenario. Sorry?
How would you manage?
Multiple ways. It depends upon what duration after it comes and what type of retroprosthetic membrane you get. Very thin membranes, avascular membranes, you can actually yak them off. Thicker membranes, vascular membranes, you will have to go into peel it. May have to combine it with a vitrectomy and peel it. And many of the cases, it kind of extends into the angle and onto the ciliary body too. So a little difficult to manage those cases.
What about the post-op glaucoma?
Yes.
How common and how tough?
I would say that comes second after RPM, retroprosthetic membrane. But then yes, quite common too. And unfortunately, the only way to assess is your fingers, and of course the disc picture.
Yeah.
Dr. Vinay, how about Oro capro differs from this Boston capro?
I'm sorry, I didn't get the question.
No, your experience on Oro capro.
Design-wise, there is absolutely no difference. Actually, the Oro capro has started based on Boston capro, and the Boston Foundation has given them permission to use the same design. Okay. Initially, there were some issues with manufacturing, getting the perfect replica of the processes, but nowadays it seems it is sorted out. But then it's not. None of the capros are available now. The recent past because of the COVID and other issues. Yeah, there's some issue with manufacturing and procuring some parts. Sorry?
They're available in phakic and aphakic, like pseudophakic form. Correct. And aphakic types, I guess.
Correct, yes.
Okay, thank you.
Okay, thank you, Dr. Vinay. I think we'll just quickly move on to the next talk. I invite Dr. Praveen to talk on mid-stromal anterior lamellar keratoplasty.
Sorry. Hello.
You're audible, doctor.
Yeah, I will be showing my own video. So please stop this one. I'll share.
It is stopped, sir. You can share your own video.
So good evening, everybody. So at the outset, I would like to thank Dr. Ilan Kumaran and COSCON for giving me this opportunity to speak on mid-anterior lamellar keratoplasty. As we all know, the keratoconus has various grades from grade 1 to grade 4. And the management of the keratoconus depends upon the grades. Earlier grades, it will be managed. You will be managing with contact lenses or with cross-linking if there is any progression, or with intacts. But in higher grades, like if the keratometry is greater than 55 diopters, and if the refraction is not measurable, or if there is a significant stria, you may not be able to manage conservatively. You have to go for a transplant. So this is the case you can see here with an advanced cone on in grade 4 keratoconus. The patient having a vision of counting fingers close to face. On in the down gaze, you will have a prominent Munson sign. You can perform a keratoplasty, full thickness keratoplasty, or an anterior lamellar keratoplasty. The problem with the full thickness keratoplasty, there is a high chances of rejection and failure, and you need to give a prolonged steroid therapy, and there is an added risk of cataract and glaucoma following high prolonged steroid therapy. So it's very advisable to go for a lamellar keratoplasty. So what are the lamellar keratoplasty we have in our basket? We can go for a superficial anterior lamellar keratoplasty or a deep anterior lamellar keratoplasty. But here I would like to show another method where is the mid anterior lamellar keratoplasty. It is in between the SALK and the DALK. Why did I come up with this technique? Because when you perform a big bubble DALK, when you're putting a sharp needle into the stroma, there is always an added risk of perforation. And when you perforate, you may end up in developing a double chamber. And sometimes it is not salvable, then you have to convert it into a full thickness keratoplasty. And as you all know, if you risk these patients for going for PK, you have to replace a healthy corneal endothelium of the patient with a vulnerable endothelium, which has a high rate of rejections and failure. The idea of this comes from the DSEC only, where you can see in the DSEC, you can give a pretty good vision with a 100 micron lenticule. So if you can retain 100 micron lenticule in the patient, in the recipient patient, then also you can give a good vision in these patients with grade 4 keratoconus. This is the patient you can see here having a keratometry of 73, mean K of 76, and the corneal thickness is around 300 microns. So nothing is possible rather than keratoplasty. And this is the Bellin ambrosia. The video you can see here. So you make 4 marks. And you don't go for complete trephination. A superficial trephination will be good enough. So now you can, with the help of guarded blade, you can give a scratch, and 350 micron depth, you can give a incision. And with the help of crescent, you just need to separate the anterior lamella. Just you have to go 360-degree peripheral separation. Don't separate at the center. You just cover the 360-degree peripheral separation. So you can get a uniform layer of anterior lamella and a uniform residual stromal bed. Then you make the trephination will be the same as you have trephined for in the recipient cornea. That is, I usually go for the same diameter. And just with the help of 16 interrupted sutures, you can secure the cornea to the recipient bed. And this is the post-op 90-day. You can see the patient's vision improved from counting fingers close to face to 6/12, and as it is an extraocular procedure and the endothelium is well maintained in the patient, so you just give a soft steroid of fluorometholone twice daily, and you can stop it after 1 year. And this is the ASOCT. You can see here the stromal, the recipient cornea, around 100 micron is there, and overlying the patient donor cornea. And this is the pre-op picture of the patient, and this is the post-op picture. And you can see this, there's a significant astigmatism because of the tight sutures. And as I remove the sutures, the cornea becomes more planar, and the vision further improves. This is the pre-op Bellin Ambrosio, and this is the post-op Bellin Ambrosio. You can see the anterior float is more green now. Then another patient having a 1 year follow-up, and the patient with having a cylinder of minus 1.5, the patient is improving to 6/6 part. So I would suggest to perform MALK. Here, the lamellar separation is a safer alternative to Unver's big bubble technique because there is a risk of perforation. A smooth stromal surface is important, is critical to prevent any form of interface haze, and preserving the host endothelium or the recipient endothelium is the utmost priority in these cases. So thank you very much for the kind attention.
Thank you, Dr. Praveen. That was a nice presentation. We have almost encroached 15 minutes of the next session. A quick question, what is your end point of dissection?
So that end point is I have to see a smooth stromal bed. How
do you say it is different from deep anterior lamellar keratoplasty? Your MALK is different from deep anterior lamellar keratoplasty.
This have done only few cases because basically I have done only 2 to 3 cases. So in these 3 cases, I could find with the 350 micron bed with the incision stab incision and separating the interlamella, I could get a clear plane and a smooth interstromal poststromal plane over which the donor cornea where I placed it is giving good results and fantastic results and fantastic outcome.
Okay.
So I'm not just meddling with the central part. I'm not meddling with the central part. Peripheral part, I'm just a little bit removing the stroma. The central part, whatever is coming in a single go, is coming out.
Okay. That careful dissection and maintaining the plane is also very important here to achieve that mid-stromal lamellar keratoplasty. Anyway, thank you, doctor. Thank you very much. That was a nice video. With this, we come to the end of this session, and I thank all the speakers for their contribution, and it has been a very interactive. And thank you all. Thank you, Dr. Ilan and the COSCON organizers. Thank you very much. Over to you, Dr. Nagesh.